Added sounds in the chest, which would probably be crackles, and I can have signs of pulmonary edema. I can have even at late stages, I can have even peripheral edema such as pedal edema and all distended neck veins. Other than this, generalized fluid overload will be there, and limited functional status.
Sure. Okay. Just to summarize, because I've just started recording, that this is a lady who has presented in labor because of failure to progress. And looking at her previous x-rays, you have found something very interesting, and you're investigating, you are examining her and sort of working on her to get to the bottom of her causes for syncope, angina, and breathlessness during the pregnancy. So you've done the examination and you've got this in mind. What will you do an ECG, and if at all, what would you find on the ECG?
I will definitely do an ECG, sir, for this patient. And a patient with heart failure, I can see left ventricular hypertrophy if it is because of LVH, left ventricular failure, or if the patient is suffering from right heart failure, then I can see right ventricular hypertrophy too. Usually hypertrophic changes will be there in ECG.
So in this particular case, what would you find?
With the X-ray, I think she's having a left heart failure because there is cardiomegaly and pulmonary edema. I think I'll find left ventricular hypertrophy in this patient.
Okay, and you have so now what is your diagnosis heading towards, and how are you going to manage this patient once you have some sort of an idea about the diagnosis? Or are you still, do you want to carry on with any further investigations, considering that she's in labor at the moment, and okay, the surgeons, obstetrician surgeons, want to proceed with cesarean section as soon as possible, as in the next hour or so?
Obviously, this patient is in labor right now, so first priority is to get her into the operating theater. If possible, and if it is readily available, I can do an echocardiographic examination. But if it is not possible, then I will proceed to the theater with the diagnosis that this patient is having congestive heart failure, left ventricular failure.
Yeah.
And I would review her routine investigations, and I would shift her to the OR. And before the patient comes there, I would plan out my intraoperative management. I would go for, there are both pros and cons of regional anesthesia versus general anesthesia, but I personally prefer general anesthetic in this patient because I can have better hemodynamic control. And moreover, regional anesthesia has the side effects of a fall in systemic vascular resistance and preload, which is not so tolerated in these patients. So my plan would be general anesthesia with endotracheal intubation. I would devise my intraoperative plan into monitoring, induction, maintenance, and reversal. So as far as monitoring is concerned, as soon as the patient comes, I would connect her ECG, NABP, pulse ox. I would take wide bore IV cannulas for fluid management. And I think invasive BP monitoring is very important in this patient. I would go for an invasive arterial line. And as far as induction is concerned, I would go for a cardiostable induction, which is IV anesthetic induction with I would give a high dose opioid for this patient because the tachycardia which accompanies the laryngoscopy will be detrimental to her. Although there are cons of giving high dose opioids such as respiratory depression and problems for the newborn, I think in the best interest of the patient, I would do a risk benefit ratio and go for a high dose opioid induction in this patient. So first I would go for an antacid prophylaxis since she's at high risk of aspiration. So I would give a H2 blocker along with a prokinetic. Then I would go for high dose opioid, approximately 200 micrograms of fentanyl, assuming that she is a middle-aged pregnant woman. And then I would give my anesthetic induction agent, which would be propofol 2.5 mg per kg, followed by succinyl choline about 1.5 mg per kg, followed by endotracheal intubation. Of course, before all these, I would adequately pre-oxygenate this patient as well. And once the tube is inside, I would check for the tube, and then I would ask the surgeons to proceed. And now my plan will move from induction to maintenance. As far as maintenance is concerned, my fluid therapy should be very judicious in this patient. I would go for a goal-directed fluid therapy, aiming to maintain a mean arterial pressure of about 65 millimeters of mercury. And I'm sorry, so 1 second.
Okay.
MAP of 65 millimeters of mercury. And further fluid management would be guided by the invasive blood pressure. 1 second, sorry. And again, my intraoperative goals would be to provide, prevent the patient from having hypoxia, hypercarbia, and acidosis. This I would do by adequate ventilatory strategies. And analgesia is very important. I would go for IV paracetamol in this patient because NSAIDs are not so tolerated well. And by the end of the surgery, I would ask for local anesthetic infiltration by the surgeons. This would be my analgesic plan. And once I'm done with this, again, extubation is also very stressful for these patients, and any tachycardia will not be tolerated well by them. So I would make sure that the patient is fully awake and having all her upper airway reflexes before I could extubate her. And that's it, sir.
If this patient was delivering normally, would you have any different challenges than doing a cesarean section?
Yes, sir. Again, it's a stressful condition, delivery is. So I would go for labor analgesic techniques, preferably giving an epidural to her. Again, that has its own problems because of the accompanied loss in systemic vascular resistance and preload. I would still insert an epidural, and I would top up in a very graded and calculated fashion, just as to make sure that she is not decompensating. Of course, this will happen in a very monitored setup with all my monitors, as I told, already in place. And the other thing is, I would liaise with the surgeons to cut down the second stage of labor by assisting with forceps delivery or anything of that sort, so that she doesn't go into any problem. And immediately after delivery, this is a very high risk period because the highest increase in venous return is just after delivery. About patients will go into acute heart failure at this time. Now, this patient on a backdrop of congestive heart failure will be at a further compromise. So I would still make sure that this has been taken care of.
Okay, that's fine. Now you are carrying on with the cesarean section.
Sure.
Any other modality you could use to monitor heart functions?
Other than the invasive line, I can go for transesophageal echo.
Okay.
Anything
else? Much slightly more simplistic than that? Because you're giving fluid to this patient.
The urine output can be monitored with Foley's catheter in situ, and invasive line CVP can also be measured, but I think invasive line will give me more information than that, sir.
Yeah. Or esophageal Doppler can also be used. Okay. So coming back to this chest X-ray, what do you think this condition could be?
I would like to report this chest X-ray. This is a plain X-ray chest PA view of adequate quality and good penetration. The trachea seems to be in midline. As far as the lungs are concerned, I can see increased vascular markings on both the sides. Costophrenic angles are good. As far as heart is concerned, heart shadow appears to be normal, but it appears to be enlarged. Other than this, bones are normal, soft tissues normal. So my provisional diagnosis with this chest X-ray could be cardiomegaly with pulmonary edema.
Okay. What could be causing this cardiomegaly? What is this white arrow pointing out towards?
Okay. Well,
You
this is
mentioned about valvular heart disease. So
okay.
if I give you the clue that this could be a valvular heart disease, what kind of valvular heart disease could this be?
Well, there is left ventricular hypertrophy. So, among the common valvular lesions, aortic stenosis would cause this, and mitral regurgitation will also cause this. Um, since there is extensive pulmonary hypertension, this could be a mitral valve pathology, sir. Could be mitral.
Okay, assuming that this patient had a replacement, where would you find the mitral valve, and where would you find the, if you could draw it on the X-ray, where
Yes.
about would you find the mitral and aortic valves?
Yes, mitral valve would be somewhere here. It would be a little bit lower and towards the left. An
Mhm.
aortic valve would be medial and superior to it, maybe somewhere here.
Okay, okay. And what about
There is-
tricuspid and pulmonary?
Um, um,
Okay, no, this is fine. This is fine.
sorry, sir,
Okay,
I don't know about that.
no problem, no problem. If you take these markings off,
Yeah, sir.
this is just a bit of a clue. You were absolutely right.
Okay.
Mitral and aortic, pulmonary and tricuspid.
Okay, sir. Okay.
Okay, just if it was a post
And I
valvular
think the
replacement.
white arrow which you were asking about earlier, I think it was pointing towards pulmonary vasculature. I'm not sure regarding that, sir. Could be due to pulmonary, that white arrow. I think it would be pulmonary vasculature, but I'm not sure.
Yeah, it was definitely. And this is actually a case of aortic stenosis
Okay.
uh, rather than mitral regurgitation or uh, any other mitral pathology, mitral
Okay.
stenosis. Uh, and yes, the patient has presented with syncope, angina, and heart failure. So any other signs that you would find on with aortic stenosis now that you've narrowed it down?
Any other signs on chest X-ray, sir?
No, on examination.
Examination, yes. Again, I can classify this first in general examination. As far as the vital examinations are concerned, these patients would be hypertensive.
Mhm.
And vitals, as far as pulse is concerned, they have the slow rising and low volume pulse, which is parvus et tardus. Other than this, aortic stenosis, they have pressure, concentric hypertrophy of their left ventricle. That is because of the pressure overload. And yes, in high stages they can have, and late stages they can have pulmonary hypertension as well because of pulmonary edema.
What are the causes of aortic stenosis?
Okay. I can classify this into congenital and acquired causes.
Yeah.
Congenital would be most common cause is a bicuspid aortic valve. Instead of three cuffs, they'll have two cuffs, which can cause aortic stenosis. And in acquired conditions, the most common is age-related sclerosis of the valve, and the other thing is rheumatic fever.
Okay. And how does it develop? What causes the aortic stenosis with the pathology? How does it progress to heart failure?
Yes, sir. The basic pathology with aortic stenosis is left ventricular outflow obstruction. So, a beating heart is trying to force a normal quantity of blood against a restricted outflow tract. So, what happens is this needs more effort from the heart. So, as a compensation, there will be muscle hypertrophy. Since this pressure overload, there will be concentric hypertrophy of the muscle. And according to Frank Starling mechanism, to a certain point, the increased contraction would lead to increased cardiac output. When it starts to fail, there will be a backlog of blood in here. So that will go into the left atrium and into the pulmonary vasculature, causing pulmonary hypertension. And as far as the forward flow is concerned, the obstruction is still persisting. So the cardiac output will be reduced. That leads to frequent syncopal attacks and angina for this patient.
Okay. Great. Let's stop here.
One symptom signs I forgot, sir. They'll be having ejection systolic murmur radiating to their
Yeah,
carotid vein auscultation. Yeah.
absolutely, absolutely.
Yes.
Yeah, you can talk about if about the severity in terms of valvular area and gradient. That's the other thing you can mention about. What else can you mention about? You mentioned about ECG. You mentioned about heart failure signs. Hypertension can be an accompanying feature. Paroxysmal and nocturnal dyspnea, orthopnea, all those features of heart failure could be present.
Yes,
that you could find in the history. I think overall, it's so this was more to sort of X-ray directed kind of a Viva, where we would first you'd start with an X-ray and then proceed towards the management of the case, rather than just presentation of an X-ray. This could easily go towards how would you perform a cardiac surgery on this patient, rather than this patient is
presenting for a
not non-pregnant subject who's a young female who has presented with features. Lateral view. How can describe the lateral view? I'll tell you what. Let me leave the X-ray description to Dr. Yasser, because he's the person who has the skills and the expertise to teach X-ray. He'll be joining the second part of this session. So Dr. Yasser will also be covering some of these topics again. So I'll ask him to describe the X-rays findings on this patient. Okay.
The white arrow pointing towards, sir?
The pulmonary artery.
Okay, okay. And left, red one, sir?
The red one is the left ventricle.
Left ventricle, right? Okay.
Yeah.
Okay.
Yeah. So that's these images are just some pure Google images. You can pick them up just to make your Viva a little bit more well-rounded, because some candidates have been asked this recently. The patients with post-cardiac surgery, patients with prosthetic valves, to point out which valve it was. That is why I've placed this Viva in cardiac. So that I think, so this could easily go towards a cardiac surgery. How would you perform cardiac surgery? What other what precautions you will take during cardiac surgery? What are the challenges? And that is the other course this could take. But bear in mind that in obstetrics, the highest mortality is caused by cardiac diseases. So that is why cardiac can very, very easily be linked to obstetric anesthesia. So that is the other reason. I can't remember the figure. I was listening to a lecture a couple of days ago. Is the highest, and it's accounts for something like 30% or 40% of the maternal mortality in UK. Okay, so I think Naveen, you're perfectly fine. You're going. This Viva was quite equivocal Viva. It should have been a very snapshot Viva, to be honest. I mean, just description just described the X-ray, but I dragged it into a few directions. But you were able to catch the key points here and able to score. The main thing is, whenever this scenario is given, how much opportunity can you take to score marks? How can you point out to the relevant areas where you can score? And I think you did just that. You started taking history from an obstetric point of view, and at the same time, because you weren't sure, you went into left ventricular failure rather than specific of a particular valvular lesion. Which is the right thing to do, because at this point, the only clear thing was that this is a patient with heart failure, and because you were not very sure whether this is a biventricular failure or left ventricular, so you were rightly pointing out towards management of biventricular failure, which is absolutely fine, which is how you should be doing it in the exam as well. So I think nothing really great from my point to suggest at this point. I think you're
I did mention high dose opioid induction because of the cardio.
absolutely fine. Yeah, this, and you rightly said that you would be concerned about the baby being quite drowsy and being in respiratory failure. As long as you let the pediatrician know that this patient has had a high opioid induction, the priority is to save the mother. You're rightly doing so. So why non-steroidals are contraindicated? Well, a couple of reasons. If heart failure, in a patient with heart failure, you would try and avoid non-steroidals because of precipitation of further fluid retention and heart failure. And
she's having pulmonary congestion and already breathless. So if NSAIDs can precipitate asthma, also that will be of concern. So I would think twice before starting NSAID. And of course, the foramen ovale as well, that also has implications in a pregnant patient. But if unless and until absolutely indicated, I will not go with an NSAID.
Yeah, and in this patient, you have already given a high opioid induction. So
that will give some analgesia as well, and some supplementation by the surgeons at the local site can be advantageous.
Yeah, yeah. And again, in normal delivery, massive increase in the intravascular volume, precipitating further. That was the other point that I was leading to, and you picked it nicely up. So the examiner might want to drag you into different areas just to draw out those specific points. But other than that, I doubt they will be very keen on you very systematically describing the whole scenario. Lidocaine given for laryngoscopic response as well. Yeah, true. And esmolol. Patient is in heart failure. Beta blockers are best avoided at this point. So lidocaine is fine, but if you're giving high dose opioids, you have actually you have avoided significant amount of pressor response. Use a video laryngoscope to do the laryngoscopy in a slick and quick manner. That is the other thing you can do to make it to reduce your apnea time and to do the laryngoscopy quickly. But I think other than that, this scenario went absolutely fine. There's nothing I can point out that you need to.
I don't know if any time Carl can come, so I have to go.
Just let us know when you're heading off, so we know that you've not gone silent. You're leaving the Viva whenever you have to. Okay.
Okay.
So Nitin has asked, what precautions can we take for I think when it comes to, so make sure that we do not overload the patient previously with fluid. Dr. Nitin has asked what precautions we can take for increased intravascular volume in normal delivery. So make sure we do not, when you're using epidural, graded epidural, if there is a drop in blood pressure, do not overload the patient with fluid. That is the first thing you can do. And cautious use of vasopressors early is the other thing you can use. Goal-directed fluid therapy, yeah, that's absolutely fine. Catheterize the patient. Make sure you're aware of what the urine output is. If the patient is dry, then yes, give very targeted boluses of fluid. Otherwise, use vasopressors pretty early on. Do not use a huge amount of fluid boluses prior to the delivery to overload the vasculature. Okay. Okay. Right, Pradeep. Thank you.
Yes, sir.
So let's start with your Viva. Okay, you have The examiner has given you an image. Let's start with this. And can you please describe this this to me? Is it too small?
It's okay, sir. I can see that. This looks to the CT scan of the chest CT scan, sir.
Yeah.
So I can see the both lungs are there. This
Yeah.
and then this black one is black. Both lungs are there, and then the middle.
Which side is the right? Which side is the right side? Which side is the left side?
So on my left is the this.
Which side is this one?
This one, yeah, sir. This one is the left. This one is the right, sir.
This is right.
Yeah, sir.
And this is left.
Also, sir, I think vice versa. This will be the left. On my right, left side will be the right, and right side will be the left.
This is right. And this is left.
Yeah.
Is that better?
I think so, sir.
Yeah.
Yeah.
Okay. Proceed. What are the structures that you can see here?
This one is in the middle. I think it's aorta.
Which one?
It's above
This one?
Above one. Yeah, so
This
one.
Okay.
Yeah.
What is
And
this?
this one is I'm not sure, sir.
No problem. So what level do you think this could be?
Or it could be.
Are these? Is this the normal size of the lungs? Or they appear they should be bigger than this or smaller than this?
If sir we scroll, I think it should be. Looks okay, sir.
Okay. So this is. I'm interested in this structure. What is this?
So this is pulmonary artery.
So if it has blood in it, why is the lung? Why is the lung and the pulmonary artery appearing the same color? Will they both appear the same color?
No, it should be air here. It's not.
So what do you think it is?
Would be esophagus.
Something that has more air than the esophagus.
Bronchus.
Bigger? Anything bigger than bronchus?
Trachea.
Yeah. Okay. So this is the trachea. Let's start with this point.
Mm-hmm.
Now try and figure out if this is the trachea. What's happening in this image?
Mm-hmm.
So this is a level of T2. T2 to T4, between T2 to T3.
T4. Mm-hmm.
Yeah. So that is the trachea you've mentioned. Now figure out what is this structure, which we're looking at. Trachea and heart should not be that close to each other. Well, it's close, but they shouldn't have that relationship. What structure can have this relationship?
This would be. thyroid, sir?
Yeah, absolutely, absolutely. What is it? What would it be called? If you find thyroid here at this level, what kind of thyroid will it be called?
Yeah, it could be. Yeah.
I think your call has come at the right time.
Maybe this retrosternal goiter, yes.
It is a retrosternal goiter, absolutely. Okay.
So can I
You want to
check
take your
my
call?
cards?
Yeah,
Yeah, so
check your call.
actually I'm
Can
ICU duty, sir. Yeah.
can anyone else take over while I'm muting Pradeep? Do anyone of you want to take over the Viva from here? Feel free to unmute yourself. Yeah, feel free to come over, guys. This is just a learning session. It's an interesting case. Just yeah, Abdul Salam. That's
Thank
great.
you.
So,
Dr. Lin.
hello, how are you?
Thanks, and you.
Good. So Pradeep has done the hard bit of identifying that this is a retrosternal goiter, right? And you
Yes.
can see that it's a left lobe which is, you can see, which has displaced the trachea towards the right. Yeah.
Yes.
This is the right side. This is the
Yes.
left side. Yeah. So
Yes.
the trachea has been displaced towards the right, and this image, this big structure is a retrosternal goiter, right?
Yes.
Yeah. Now,
Yep.
what will happen to if you do a flow volume loop analysis of this patient? How will the inspiration and expiration look like?
It's this volume structure which have an obstructive effect on the trachea. It's
I have drawn the flow volume loop curve for you. Now try and draw the rest of it for me.
yes, it's like this.
Yeah. So if it's a fixed obstruction, what happens?
It's upper fixed obstruction. It's fixed upper obstruction of the trachea. We have first we have as clinical we have wheezing, and this it's like this. I don't have to like this.
Mm-hmm.
The inspiration is small as the flow. The flow inspiration is little, and the expiration is not be much effective.
Okay. Okay. What happens if it's a variable obstruction? If it's extrathoracic obstruction?
You want me to draw a flow? What? I don't understand.
Yeah. If it's extrathoracic, how will the flow volume look like on this?
If extra, I think like this. It's small data. I think it's small.
Okay. I think you okay. Dr. Yasser is also joined in as well. Okay. Okay. Let's we'll share the images with you. That's fine. I think your pointer has got some issues, so you're struggling to draw. Okay. Now that you've joined in, let me give you a quick scenario. I'll just put a timer for you, and let me just give you a quick scenario. You have a patient who has aspirated, and the patient has been brought to ICU, right?
Okay.
You you want to figure out what was the patient's position at the time of aspiration. So on X-ray or CT scan, what will be your findings that will suggest what is the patient's position at the time of aspiration? If you tell me, if the patient was supine, what will you find? If the patient was the right lateral, what will you find? If the patient was left lateral or the patient was sitting, what would you find in the X-ray or CT findings?
If the patient, if we begin with when the patient is supine, we'll have in the left side, we have patient in the left side.
Is the left bronchus more straight, or is it the right bronchus which is more straight?
Is the left.
Okay, so the aspiration will go on the left side.
On the left side.
Okay. What happens if the patient is on the right lateral side?
In the patient in the right.
Patient is lying on the side, on the right side down and left side up, and aspirates. What will you find?
We'll find in the right side.
Which, yeah, of course, but which part of the right side? Which areas of the right?
In the upper, in the upper lobe.
So upper, but can you tell me exactly which subsegment? Okay. What about prone? What happens if the patient is prone and then aspiration occurs?
When in the patient in the prone, we have in the symmetric side.
On the?
In the right side. And the left. Yes, symmetric side. Yes.
Oh, both equal.
Both equal. Yes.
Okay. Okay, that's great. Fine. Okay, I'll just give you the answer here because it's so if the patient is supine, most of course in 1940s and 1960s the description of aspiration was quite different and the findings were different. The aspirations were a lot of aspirations were happening on the dental chair as well, so the presentations were quite different. Patients were a lot more of them were sitting up. When the patient is supine, then you get the superior segment, yeah, of the right lower lobe. Bear in mind, the right bronchus is more straight than the left bronchus.
Okay.
Yeah, that is why aspirations happen mainly on the right side.
Okay.
Predominantly on the right side. So let me just share an image with you. Can you see these bronchopulmonary segments?
Yes.
And these are the different lobes. Yeah.
Yes.
So when the patient is supine, the aspiration happens in the superior segment of the right lower lobe. So you have the right lower lobe here. Oops. That's your right lower lobe, right? Yeah.
Yes.
And in the right lower lobe, you have this segment as the superior segment. This superior segment is split partly between the lower lobe and partly between the middle lobe. As you can see here, it's in between these two. It's in between middle and inferior lobe. So you will have the aspiration mainly in the superior segment of the right lower lobe. If the patient is on the right lateral position, right side down, left side up, then you will have axillary subsegments of anterior and posterior right upper lobe, right? You have anterior, this one, right? The green one, and the blue one is the posterior. Both of these have an axillary subsegment. That is where you will have the aspiration when the patient is on the right right side, right lateral position, right side down, left side up. Are you with me, Abdurrahman?
Yeah.
Abdussalam?
Yes.
Yeah? So these two lobes will be predominantly affected when you have patient on the right side. This will be predominantly affected when you have patient being supine. That is the superior segment of the right lower lobe. This bit. Okay.
Okay.
Prone, very, very rare to have aspiration in a prone patients. Yeah.
Yes.
And as far as the abscesses are concerned, left lung abscesses, they are predominantly in the basal basal segments of both sides. So lower lobes and basal segments. So lateral basal or anterior basal or of right, and equally on the lateral basal and anteromedial basal of the left. But abscesses are not that important. It's the aspiration that is more important here. So just try to revise that part as well. If they ask you about which segment will be affected in aspiration, so this will be your thing on that. What investigation will you do if you have a patient suspected of aspiration?
I begin with the X-ray for him, and I would do him ABG also.
Okay. And if the aspiration has happened on the table, when you are actually anesthetized, when the patient is being anesthetized, you had an LMA and the patient had aspirated, how will you manage it at that point?
First, I will speak to the surgeon to stop the surgery. I call for help and call my surgeon. Then I put the patient otherwise in the right side, and I will remove LMI and do. I will use the device to with the high suction to aspirate to do the suction of oral, and I try to intubate to secure my airway and put FIU to 100.
Will you flush any saline down the airway to aspirate? Do you do any lavage at that point?
I can use it, yes. I can use it, yes.
What happens when you do the lavage? Will you be able to suck out the food content?
Oh, sorry, Dr. Danish, can you repeat?
Will you use saline lavage? Will you use saline lavage when the patient has aspirated?
No, I don't use anything because I will measure the aspiration for him.
Yes, you'll go further down. What about bronchoscopy? Can you do any bronchoscopy at that point?
I will do later when when the patient will finish operation. I do later for him in the recovery room or in the ICU after.
Yeah. Fine. Okay. What could be the outcome of this aspiration? What could the patient develop as a result of aspiration?
The aspiration might be maybe develop atelectasia, and later maybe develop pneumonia after. And in the worst case, they can develop RDS.
ARDS, yeah.
The worst things, and this is the evolution of causing the evolution of the patient. They can extubate him after if they develop after RDS. we shift him into ICU. It's according to the evolution of the and the mouth of the aspiration also.
Which one? Sorry, mouth.
The quantity of aspiration.
Amount of the aspiration. Okay. Okay.
Amount of aspiration,
Okay.
yes.
Okay. Fine. Let's stop here. Pneumonitis, pneumonia, yeah, ARDS. All these are complications from acid, and you never do a lavage. You rightly said it would displace the aspirate further into the deeper levels and will spread it. It will be difficult to take it out on further bronchoscopy. So there were some people who answered in the past about using bicarbonate suctions and for acid and all that. That will cause more damage, anything like that. So no suctions, no lavage with any sort of fluid. So just do a proper suction as you can. Yeah, you can use, definitely you can use bronchoscopy as early as you can use it if the patient is stable. If oxygen head down, yeah, put the head down as much as yeah, to bring the gravity use gravity in your favor, and that will help in retrieving the aspirate. And yes, if you have skills to do bronchoscopy, and if this bronchoscope is available, then absolutely, the sooner you do it, the minimal damage will happen, and you'll be able to get away with least damage as possible. So don't think of doing it in ITU. Do the bronchoscopy while you're in theater if you can, if you know how to do it, and if you can ask a senior or someone specialized to do it.
So what is the sequence? What is the sequence of event? What we should do after once you know the aspiration is happened? So what is the sequence? We have to do the first, as you stated, with the head low.
Call for help. 100% oxygen. Head down. Aspirate as much as you can. Intubate the patient, and at that particular point, first do a bronchial suction. If you can achieve it blindly. In the meantime, when you get a bronchoscope, then do a bronchoscopic guided aspiration. Okay. And also try and put the PEEP up a little bit and try and reduce the volumes at that point. Go to lung protective ventilation right at that particular stage.
Yeah. So I think before giving IPPV, which in the positive, you should suction properly. Yeah?
While you're giving.
Before you start doing a positive pressure, before you ventilate the patient, I think you should do proper suctioning of the lungs, so it will not displace whatever content is there in front. You can remove it.
Keep the head down while you're able to sort of drain it as much as possible. And if the patient is desaturating and you have to continue with IPPV or oxygenation to maintain the oxygenation, then it's a different story. But before actually causing significant shear forces to come into play, try and suck out as much acid and food particles that are in that area. Okay. So yeah, I don't think it has been asked, but I thought while you're doing thorax, and it's a good idea to have an awareness of which segments can get affected, and if you do land up in aspiration, then how to manage aspiration in theaters. Because I remember in the past, some candidates did mention about using bicarbonate lavage, which it can cause twice the damage. Then on one side it's acid damaging, and the other side is the alkali damage. So do not use any fluid to cause to do any lavage at that point. Okay, that was great. I think let's stop there. Abdussalam, thank you very much. Well done. It's a very sort of awkward kind of a question, but it gives you some idea about aspiration, which segments get affected, and where would you how would you manage if there was an aspiration in this case, and how would you treat aspiration going forward. Okay. Perfect. Thank you very. Thanks. Thank you very much. Let's. We might have one more before I hand over to Dr. Yasser. I'll take one more Viva. Who wants to come in first for this, for the next one? Abdussalam, I'm muting you. Dr. Yasser, you're around here.
Yeah. I was just wondering if I can do this one, if that's okay.
Yeah.
And I can.
Before you start, Dr. Yasser, Nitin and someone else has also asked to comment on this chest X-ray, which I had shown them of a patient with aortic stenosis. Especially, they wanted to know about the lateral view. That if a lateral view, it's very unlikely that they'll give you a lateral view. It's AP or PA views generally speaking. But if they do give a lateral view like that, what would they expect from a candidate?
Well, I don't know whether they will actually give you a lateral view of this kind of situation. I think primarily at the best you can see calcifications, and as it is known that aortic stenosis X-ray changes are quite late when you have generally heart failure, and you can see a big heart on the chest X-ray, or you could see a calcified wall or annulus. I mean, those are the things that you would see. But on the lateral view, I'm not sure what else you can see apart from calcifications.
No, yeah. I think there's nothing very, very significant. It's mainly based, most of the findings are on the AP view actually of hypertrophy. And as you can see, even the pointers are given on the AP view, on the PA view.
See dilatation of the left atrium in severe, but not really. That's I wouldn't comment much on lateral views. Yeah, I think so.
Okay, I'll leave it at that.
Yeah, that's fine. Thank you, Nitin. Okay.
Thank you. Thank you very much.
Let's stay. Let's start. Can you explain to me what is the normal process of hemostasis in the body?
Hemostasis will be like intrinsic pathway and extrinsic pathway.
No, that's coagulation. Hemostasis only. Which is in totality, coagulation pathway is part of hemostasis, but how does hemostasis occur?
So how can I start? Sorry.
Okay, you can start from an injury somewhere in the body, right? An injury occurs, and that injury leads to formation of a clot. Now you have to explain me the journey from the injury to the clot, the whole process from the point of injury to the point of clot formation. That is hemostasis, because once the clot is formed, the bleeding will stop.
So okay, there will be tissue damage, then tissue factor will get activated.
Why does that? Sorry, give me a second. Okay, sorry. Okay, so you said tissue damage. That's right. So what does the tissue damage lead to release of what factor did you say?
Activation of the tissue factor, the TNF and tissue necrotic. Yeah.
So you said tissue damage. What does the tissue damage cause release of the factors? Which tissue are you talking about?
Means any vascular epithelium or some damage will happen?
Yeah, not the epithelium. It will never come out from the epithelium, right? It is the endothelium, right? Vascular endothelium. So bleeding comes from blood vessels, right? And when we are talking about blood vessels and clot formation, it all comes from the inside of the vessels, the endothelium. The outside epithelium doesn't actually release much factors. It would be the endothelium that is important, right? So tissue injury causes disruption of the vascular endothelium. And what happens to that?
And after that, activation of the platelet activation will be there, and all clotting factor will start. Means it will be extrinsic pathway will activate.
So how does platelet adhesion take place?
I read it long back.
Yeah. Okay, that's fine. So that's okay. Once the whole platelet thing processes and coagulation factors get activated and coagulation pathway gets activated, what happens then?
Then the clot will be initially it will be weak clot. Then it will thrombin from prothrombin. The thrombin will convert and it will make a very this one.
Okay, so if I put it this way, what is primary hemostasis and what is secondary hemostasis? Okay, that's fine. Now, can you explain to me how you manage anticoagulation for a cardiac bypass procedure?
For cardiac bypass procedure?
Yeah.
Yeah, so if patient is posted for cardiac bypass surgery, so we have to go through the history about the patient, whether the patient is on any anticoagulant before, is because he is a cardiac patient, he must be having some anticoagulant in the form of antiplatelet like aspirin or clopidogrel, or if he has
no. We're talking about intraoperative management of anticoagulation for a cardiopulmonary bypass procedure.
Okay, so in intraoperative, okay, after induction and once this stenotomy means after induction, patient is already intubated with all monitoring, and once they will do after stenotomy, before going on bypass or before they cannulate the aorta, we have to give a high dose of heparin, that is 3 to 4 milligram per kg. And after giving heparin, we have to measure this anticoagulation acid activated clotting time after 3 minutes. Usually we are measuring after 3 minutes, and then we'll check the ACT. If it is more than 450, then we can go. They can cannulate the aorta and they can begin with the CPB.
Okay. How often do you monitor ACT?
Usually, every hourly we used to manage. We used to do the ACT and ABG during bypass surgery.
Okay. And how do you reverse heparin?
So heparin, usually we are reversing with the antidote protamine. So protamine, usually we are giving the same dose. If you are using 1 milligram of heparin, so you should use 1 milligram of protamine. It is same ratio, but in some cases, if we give heparin a little bit longer time. If it is after giving one dose, if it is 1 hour is there, 1 hour already spent, then we are giving half dose instead of giving a full dose reversal.
Sorry, say it again. Why do you give half dose?
Usually because of the if heparin given little bit longer time before, like 1 hour before or something, we gave heparin, and if you want to reverse, in that case we are giving half dose, because there will be some metabolism of heparin. Heparin will get metabolized in the body, and it will utilize in the circuit as well. So at that time, we will sometimes we are using half dose of the protamine instead of giving full dose of protamine.
What are the tests that you use for coagulation in the intraoperative period?
Intraoperative for to check the heparin effect, we are usually activated clotting ACT we are doing. And at the same time, you can do the, if we are suspecting some bleeding or some or too much bleeding is there, and we are there is no surgical bleeding, we want to rule out the medical bleeding, so I think we can do TAG in intraoperatively to see what is the cause of bleeding, whether it is factor phase frozen plasma is require, or CRAVA require, or platelet dysfunction is there, platelet, so we can accordingly we can manage.
Can you draw me a normal TAG graph?
For TAG, hello?
Yes, normal TAG. Can you hear me?
Yeah, I can hear you.
Can you hear me?
Yes, sir, I can hear you, but I cannot see.
Can you?
I can hear you, but I cannot see anybody.
Can you hear me?
Yeah, I can see you now. I can see you and I can hear you.
Yeah, normal TAG is doctor.
Normal TAG. Okay, I will draw. Alpha milliampere at 10 minutes, 20 minutes. It may look like this. Can you see?
I think we've lost him. I can see it. I think Dr. Yasser, I think we have lost him. Yeah, his connection is off. So what is the R time in this, and how much is the, what is the PA?
There will be R time. It is the initiation of the clot formations from the once you put the sample, so it will show the initiation of the clot formation, and then there will be alpha angle and this one maximum. I also forgot. Alpha angle and R time both will show us clot formation. I'm not sure.
What is the PA? What is the maximum amplitude? The maximum PA value?
This normal value.
Now, what is the significance of that?
What is? So maximum amplitude, it will.
And what is the significance of, yeah?
If any deficiency of fibrinogen is there, or platelet dysfunction is there, so this maximum amplitude will go down. Will decrease.
Sorry. Okay. Yeah.
You can
hear
share
me
the. Yeah, you can share the diagram with Dr. Yasser. I was just continuing on the scenario.
I don't know what happened. My computer, the Wi-Fi is, I think, broken down. I'm just gone on my mobile now, so at least I can connect to my mobile.
I've done the same. My Wi-Fi broke down at the same time. So I've gone on my phone as well.
Okay, okay. Sorry, Nitin. You were telling me about TEG.
Yeah.
Yeah.
I tried to do, but I'm not. I didn't know the normal values of this. And so first will be the R time, then alpha angle will start, and then maximum amplitude will be there. At maximum amplitude, we are usually seeing at 10 and 20 minute durations. And then fibrinolysis will start later on. I think maybe 40 minutes. Initially, there will be R time will showing the clot formations. It will beginning of the clot formations. It will show us.
Yeah, that's fine. That's good. Can you tell me, now that you showed me TEG, in case of patients who are who have got problems with heparin, alternatives
I cannot hear.
Use?
I think the signals are dropping on
Yeah,
your
signal is dropping in between.
Can you hear me, Nitin?
Now I can hear you, sir. Before it was, there was no.
Yeah. Sorry, we're having some problem with the internet. I don't know what's happening. Yeah. Okay. Can you tell me if you have a contraindication for heparin? Wait, I might be coming on the computer as well. So.
Yes, I can see you joined on the computer as well. Try using your Wi-Fi connection, your broadband connection.
Okay. Can you hear me now? Is that better?
Yes. Yeah, now better.
So what options do you have if you can't use heparin?
If you cannot use, and if you want to go on bypass.
Yes.
So it is, you are talking about insulin resistance. If patient having insulin resistance, or what are the means?
If there is any issues with heparin or contraindication to heparin, what other drugs can you use to anticoagulate for cardiac bypass?
There is one heparin analog is there. You can use it is I think biliverdin.
Yeah, biliverdin. Yeah, bivalirudin.
Bivalirudin.
And any other drug that comes to your mind?
I'm not sure.
Okay, lepuridine and danaperoid.
Danaperoids.
Yeah, danaperoid, lepuridine, and bivalirudin. So now, briefly, before I just want to ask one more question. What are the causes for low blood pressure after a cardiac surgery?
So it will be cardiac surgery after hypotension. After cardiac surgery, it will be because of the surgery itself and because of the how can I classify? Okay, surgery. Okay. Okay, so if it is surgery related, there will be some issue with the graft. If it is graft is not properly done, there will be ischemia, ongoing ischemia that also leads to this hypotension. Second thing, there is and it will also lead to low EF. Then there will be continuous some arrhythmia is there on the screen and some electrolyte imbalance there. If there is a metabolic disturbance is there, like acidosis, severe acidosis is there. So that is also one reason for hypotension. Then third thing, if LV is low, very low ejection fraction is there, then there is also one cause of the hypertension. Then usually we are giving protamine for the reversal of the heparin. There will maybe chances of protamine reactions. And we are most of the time we are in cardiac bypass surgery. There are frequently we are using the blood and blood product. So there will be reaction from the blood and blood product will be there. Then different type of arrhythmia it come. Then one more thing is I think systemic inflammatory reactions syndrome. Because of that, there is profound vasodilatation will be there in the body. So there will be hypotension. And then, but one more cause is bleeding. It's continuous bleeding is there, some oozing is there, some bleeder is there. So because of the continuous bleeding, there will be hypotension. And what else?
So if there is hypertension post-cardiac surgery, which is not responding to inotropes and vasoconstrictors, what options do you have?
If it is not responding to inotrope, then we have a there is IABP. We can use IABP, intra-aortic balloon pump.
What is IABP?
It is intra-aortic balloon pump. So,
what is it? What's the terminology for it in terms of what it does? How do you define it?
Yeah, intra-aortic balloon usually inflate during the diastole. So it will increase the diastolic filling of the coronary and increase the coronary perfusion, and it will decrease the afterload. So it will give a more space, more room for a LV to contract, and it will help the LV to increase its cardiac output. By
how does that happen?
So
what
during
what do you mean by counterpulsation? It's also called counterpulsation.
Counterpulsation.
So what is the idea of counterpulsation?
So it is counterpulsation means whenever LV is ejecting, it will deflate. The balloon will deflate. So yeah, and then it will give a room for LV to increase this cardiac output. And when it will relax, it will inflate. So it will increase the diastolic filling of the coronary.
Okay.
So if any graph problem is there, some problem in the graph is there, it will increase the coronary blood flow, and it will help to overcome the ischemia or something is there in.
Okay, that's fine. That's good. Any do you know of any complications that can happen because of intra-aortic balloon pump?
Yeah, the complications with intra-aortic balloon, it's a complication related to procedure. While you are putting the intra-aortic balloon, there will be chances of the bleeding, first of bleeding, and then this bleeding may be, sometimes it will be very, this one, problematic. It will lead to retroperitoneal hematoma. Then it may rupture during after insertion. It may rupture. It may emboli this balloon. Then it may injure the aorta during insertion and this time of position. Then
what does balloon rupture do?
It will embolism of the balloon materials. Usually it has a helium, it will not do any air embolism, it will get absorbed. But the product of the balloon, it will get embolized.
Right, okay. Any contraindications for intra-aortic balloon pump?
Yeah, first at the site of insertion, there is infections. Then if patient had a aortic dissections, we cannot put and aortic stenosis as well. And what else? Aneurysm, aortic aneurysm is there. And severe aortic regurgitation is there. And peripheral vascular disease, it is there. It is relative contraindicated. Absolute contraindicated is only aortic dissection and infection at local sites.
Okay, that's fine. I'll stop you here. Look, I'll tell you one thing. Your knowledge is good. You know, your knowledge is good. So you should. I mean, this is a very. I'm not sure whether they will be asked such questions, or do they ask these questions in EDAC? Because I don't expect cardiac anesthesia as such to be a specialty where you'll be tested. But however, it's an important area. Maybe you'll get asked. There were a few small things that I would add on. You need to be confident and keep on whatever you say it a bit slowly. Give time for the examiner to absorb what you're saying. If you say a bit faster, maybe some of the key points you are mentioning, they will not get across to the examiner. In terms of knowledge, as I said, it is good. I just wanted to add on a few things. Like I mentioned, what is the mechanism of hemostasis? Hemostasis is the whole thing, coagulation plus stopping the bleeding. So it has got basically three main components to it. One is immediate injury to the vessel wall will cause vasoconstriction. So the idea is to stop bleeding, isn't it? So immediate injury will cause vasoconstriction. The second thing is platelet plug formation, right? Platelet adhesion to the collagen that gets exposed with the vessel disruption. And all the mechanisms like von Willebrand factors binding and then platelets adhering, which give rise to a platelet plug initially, which is called primary hemostasis, right? And then you have all the coagulation factors getting into activation into that pathway. And that pathway leads ultimately to produce thrombin. The thrombin converts fibrinogen into fibrin, right? And fibrin, then that fibrin strengthens the clot that's formed by the platelets, which stabilizes the platelet plug eventually and makes a very firm clot, which stops the bleeding. So it is first vasoconstriction, first stage. Then second stage is primary hemostasis, which is mainly platelets and von Willebrand factor and the collagen. And the third stage is about secondary hemostasis, which is coagulation pathway activation, and then mainly towards the end, forming thrombin converting fibrinogen into fibrin, which stabilizes the platelet plug. Is that it? If you think in the bigger picture, you have three main events: like vasoconstriction, platelet plug formation, and then coagulation pathway activation, which leads to fibrin forming from fibrinogen, and then fibrin stabilizing the platelet plug. Okay, that is secondary hemostasis. So then the coagulation pathway you can explain in more detail, but the key events are that leads to formation of thrombin, and thrombin changes fibrinogen into fibrin, right? And that you can actually explain on TAG as well, but you explained TAG in a good way, which was good. Heparin and anticoagulation and protamine things, they are quite important to know for cardiac surgery. So you said that rightly. You give either 4 milligrams of heparin per kg body weight, or you give 100 international units of heparin per kg body weight. 500 international units of heparin per kg body weight. And that is the dose usually you use, but you look at the baseline ACT first. What is the baseline for that patient, and then give heparin. And then you will look at the ACT, which should be about 3 to 4 times the baseline. And roughly, if you are about 450 to 480 seconds, if the ACT activated clotting time is more than 480 seconds, you're good to go on the bypass, right? That is what we usually think. But also remember, there is 5,000 international units of heparin in the priming solution in the cardiopulmonary bypass. Yeah. So you have to take that into account when reversing the heparin. Okay, and monitor ACT every 30 minutes during the cardiopulmonary bypass. Okay,
every 30 minutes.
So every 30 minutes. So. The other thing is, we mentioned alternatives of heparin, especially if there are any contraindications like heparin-induced thrombocytopenia. You can think about low molecular weight heparin like danapiroid or lepiuridine or bivalirudin. right? Bivalirudin. These are the 3 other drugs you can say. And you rightly mentioned protamine dose, 1 milligram to 1 milligram heparin or 1 milligram to 100 units of heparin. That is the protamine dose. You have to be careful with protamine because it can lead to hypotension. So give it slowly, and make sure the surgeons are aware before you give protamine, right? You have to always tell them. And Teg, you correctly mentioned, I like your diagram. That was fine. That was not an issue. Now, in terms of hypertension post-cardiac surgery, you were saying all the right things, but you were saying them a little bit jumbled manner, because basically either it could be hypovolemia, which could be bleeding, or it could be secondary or relative hypovolemia related to your sedation, related to rewarming, which can lead to peripheral vasodilatation, you know, or what you also have to mention, importantly, cardiac tamponade, right? That is very, pick out the important ones. And then left ventricular dysfunction, secondary to many causes. It could be reduced contractility, it could be myocardial stunting after the bypass, it could be existing poor ventricular function, or as you mentioned, the problems with the graft, right? Then you mentioned biochemical problems like metabolic problems, acid-base problems, and also sometimes increased afterload, fluid overload. That can be a problem. So yeah, and then arrhythmias. You did mention arrhythmias. That was fine. Then there could be some coexisting problems like sepsis, right? Sometimes if sepsis is there, for example, a patient comes in septic shock secondary to infective endocarditis, so that sepsis can lead to, and one thing you rightly mentioned is anaphylaxis secondary to maybe protamine, which is known to cause anaphylaxis sometimes. One more thing I would add to this list, which is uncommon but can happen, is adrenal insufficiency.
Okay.
Right. So mainly you're talking about important problems like bleeding, hypovolemia, then tamponade, which is very important to mention post-cardiac surgery. Then you'll talk about your sedation, rewarming, vasodilatation related to that. Then you will talk about the heart itself, myocardium, left ventricular dysfunction, inadequate reef perfusion because of the graft not working properly. Myocardial stunning is very important post-bypass, right? And poor existing ventricular function. And then this is heart. First is the bleeding, second is heart, third is about metabolic problems, and then fourth is arrhythmias, fifth anaphylaxis. What else was there? One more thing I mentioned. Anaphylaxis. Sorry.
Infection.
Yes, infection, sepsis, and lastly, if you can remember, adrenal insufficiency. If you say so much, that is a lot of things. Briefly, I want to mention to you about intra-aortic balloon pump. It's called as circulatory assist device. Okay. Right? Or it is also called as contrapulsation balloon pump. So you're right, it inflates in a diastole, it deflates during the systole, it helps in filling up the coronaries in the diastole, and it also decreases the forward flow. It decreases the vascular resistance ahead of the heart, which improves the forward flow, right? And you are all good about that. I don't have to go into detail. The indications we mentioned, there are a lot of indications mainly for this. You can check that out. But the contraindications would be aortic regurgitation. That will be a contraindication. Aortic dissection would be a contraindication. And then if there are any aortic stents, then that will be a contraindication, right? Problems with it will be twofold. One is the procedural, you mentioned those. The other thing is don't forget the limb issues. So loss of pulses in the limbs, compartment syndrome in the limbs, limb ischemia, thromboembolism, and that's all coming from limbs. Remember, you put it down there in the aorta and the circulation to the limbs can be compromised. So that is one. Second is dissection. You mentioned injury to the vessels. Rupture of the balloon, and that causes gas embolism. Balloon entrapment sometimes happens with counterpulsation balloons. So your balloon gets stuck there. That's the problem. and infection if the balloon is there for a while. Okay, and also it can lead to renal compromise sometimes. So you have to always make sure that they're above the renal artery. Yeah, but sometimes it can lead to renal compromise as well. Okay.
Yeah,
that's all from me. But you are doing fine. I mean, I'm just trying to if I can add on something. But overall, it was good. I think others might agree, and Dr. Danish, I hope you agree to what I'm saying as well.
Yeah, no, absolutely. I think, as you rightly said, that in EDAC, this is, I think, way beyond the punching mark, actually. So if you know this much and you are attempting cardiac questions, then you'll very easily clear that section. So it's mainly they sometimes dive deep, but they are more about touching on superficial areas and then pick up just one of those areas and go a bit more deeper on that. So if you're lucky, then the area that you know very well, it can be picked up. But appearing confident is very important, Dr. Nathan. You're very knowledgeable, as Dr. Yasser pointed out. You should sound confident. That's really makes a big difference.
okay.
And one last thing for everyone: whenever you think about clotting, you think about these in a bigger picture. You think about the stopping of bleeding, and that is mainly either vasoconstriction, platelet plug formation, and then the clotting activation mechanism. Hemostasis is a complete picture of everything, and the coagulation pathway is only coagulation pathway, and that is a little bit different. But in hemostasis, you are trying to achieve everything to stop bleeding. Okay, well, I'll stop here. Thank you very much.
Thank you very much. Thank you.
Thank you, Dr. Yasser.
Sir, one more question, if I can ask about the CT scan. So, can you describe the different level of CT scan and how can you diagnose the CT scan level? Because you will, I don't know, I'm still not that confident in that. How do you decide left side, right side, and
the CT scan?
Yeah.
Let me take it off. Give me 2 seconds. Okay. So that's your scan here. So imagine that this is an image that if you are watching the section from underneath, the patient is lying down on, and you are watching it from the foot end. Yeah.
From the foot end. Okay.
From the foot end. So when you watch on the foot end, the head is beyond. It's buried in the depth of the monitor. The foot end is towards you. So now if you look at it, the right side that you see on the screen is actually patient's left side.
Okay.
Can you imagine it that way? The patient's head is somewhere deep in the, you can probably
monitor.
Just about, somewhere just about there, see patient's head and nose, and probably just, that's the patient there, right?
Okay, fine. So can we, okay, I got it. So we can say it's right or right. Okay.
So this is going to be the right side. This is going to be the left side. Anterior, posterior will remain the same. This is the anterior and this is the posterior, depending on if the patient is prone or supine. But if the patient is supine, then this is how it will remain, anterior and posterior, and right, left. I've never seen a prone CT, but I'm just saying that the orientation, basically, you have to know right and left, which is very important.
This is reverse. I think right this side will come.
Oh, sorry, I have made the mistake myself. Sorry.
Okay.
This is the left side. This is the right side. This is the anterior side, and this is the posterior side. Sorry, apologies. I got carried away.
And but different level of parts. How can we? They can.
So you have that. The examiner will tell you. But what you need to know when you're looking at the CT is what are the other structures? What are the proportions? So sternum is quite an important point. At what level can you see the sternum? And if you can see any ribs or any clavicular, sternoclavicular junction, if that is becoming very clear. Sternum, scapula is also very important here. That what can you see? Can you see the spine of the scapula, or can you see just the blade of the scapula? That will tell you an idea whether it's T8 or it's further lower down. The level is further. If you're seeing the spine of the scapula, then you know that it's quite high up. Second, the third thing is that you can see the proportion of the lungs. The lungs are not that big in this image. The lungs should, ideally, in terms of the right proportion, the lung should be a lot more bigger in a CT image, and you should be able to see the heart. This was confused for heart. Yeah. Now, heart
very high up.
Yeah, high. Again, the heart. You should see some element of trachea. You should see some element of esophagus if possible. But trachea, at least, you should see where quite central. If this is a pathological thing and you're seeing something, I can share a CT scan with the heart in it as well. CT chest. Let's say, shall we share T4 value? Yeah, T4 angle level. So let me just. Oops. Now look at this. This is at T4.
Okay.
Right? Can you see the proportion? The
lungs, yeah.
Lungs, yeah. They're
Lungs
significantly bigger, yeah. And again, what do you see at T4 here?
This is, I think I can see the trachea in center.
Yeah. You can see the trachea in the center there. And you can see quite big sternal body is quite big here at this point. Yeah, ribs are again you can see the scapula. The spine is not that big, and this maybe with the I mean, I think scapula may not be a very good differentiating part, but surely the proportion of the lung is very important. Heart hasn't appeared here at this point. You can see that this is just lungs are seen, and you can't see the bifurcation of the trachea at this point. Maybe it bifurcates slightly lower down. And what is this structure then?
This would be again thymus.
Yeah, quite big actually. If it is thymus, T4. I don't know. I haven't studied this image. I just pulled it up from the internet, so it's hard to say at this point what it is. Whether it's a what will be the relationship of aorta to the trachea? Will it be anterior or will it be posterior?
Aorta will be posterior, no? It will be
yeah.
It will be in front and it will be posterior.
Yeah. So you would that will not be the case. That will not be the case. But the basic orientation is having the left-right orientation right. Looking at the window as well. This window, maybe pulmonary artery, possibly pulmonary artery. Yeah. So yeah, I don't know. It's difficult to guess. I mean, I'm not a expert on thoracic CT, but the main thing is which window they're showing. Is it a lung window? Is it because in lung window, then you can see the bronchiovascular margins very clearly. You can tell whether the patient has atelectasis or consolidation or effusion. that will be, then the examiner is clearly wanting you to comment on the lung parenchyma. When the lungs are completely dark, they're clearly not interested in the lung pathology. That is something you can rule out straight away. It's either cardiac or it's something else. So in this particular image, it was quite obvious that there's nothing in the lung window. Yeah. So something. Those are small clues you can probably pick up in these sort of in these images. But again, in the heat of the exam, it's not the easiest thing to pinpoint in that regard. Okay.
Thank you very much.
Thank you. You're welcome. Thank you. Let's start with the next scenario. Who wants to come in here for the next one? Okay, I can share with you the image. So Naveen or anyone else who hasn't appeared. Yeah, sure.
Yeah. So this is angiography.
Oops, sorry. So sorry. I always do it the other way around. I was supposed to show you an image where they were not labeled. So I started. Sorry. Okay, let's start with this. Yeah,
So this is a film for angiography. It is they did the left shoot. Here you can see there is a catheter, and from that we injected a dye. The first is left main, that is getting bifurcated, and the upper one is left anterior descending artery, and the lower one is a left circumflex artery. And in between there is ramus. Is going. It is between the LAD and circumflex. It is a ramus artery. And these are from this one circumflex. There are some branches coming out. This is obtuse marginal branch are there.
So is it a right anterior? This is a right anterior oblique view. Okay, just to clarify.
Okay. Yeah. Okay. Right anterior oblique. RAO view.
RAO view. Yeah. RAO 30 degrees oblique. So in that light, can you point out which one was LAD?
How to use 1 minute check? Check. I don't know how to use it. So, 1 minute. Yeah, I got it.
You got it? Yeah.
Yeah. So this one is LAD. This blue. This one is LAD. Yeah. This one is left circumflex. This one. And in between there is a.
I'm not able to see a mark. Can anyone else see the mark on the screen? I'm not able to see a mark on the screen. Yeah, it's appear now. It's a bit delayed. Yeah. So which one is LAD? The one at the top?
One of the top is LAD, and then with two arrow is there. It is circumflex, and between the LAD and circumflex, there is one more branch is going. This one. This is ramus, and this whatever branch is coming from this one, what we call circumflex. It is a obtuse marginal branch, OM branch.
Yes.
And this is left main. This is left main. Last one.
So this is the obtuse marginal branch.
Yeah, this one. It is delayed. It's showing delayed. I already mark it, but it is not showing now.
Oh, I see. Sure. Okay. So that's perfect. So let me just. That's right.
This is catheter. Last from left side, it is coming. It is catheter.
Okay, yeah. Okay, you're absolutely right. Let me just, if you clear your screen, then
Okay,
I
sir.
will,
Clear.
I will,
Okay, I clear it.
yeah, I will just change the image. This is what you've just mentioned. So this is, this particular image is right anterior oblique image of, yeah. Can you guys see the bigger version now?
Yeah.
In this image, the whole idea is to recognize the pattern. The LAD will always be at the top, and the circumflex will always be the one coming down on the side. So LAD is always going to be this vessel here, and that will be the circumflex that will come down from here. So let us move to the other image. This is that one was right anterior oblique. This one is left anterior oblique at 60 degrees. What
this is
the,
before it was RO, no? This is left.
Yeah. This one is LAO,
LO.
left oblique.
So I'll check. And okay, so this is again left main.
Yeah.
And then this is LAD. That is going toward the apex. It is LAD.
Yeah.
And the branch behind it is.
There's a bit of delay, I think, in your.
Yeah, it is coming and going.
Touch. So I will do the marking, and you tell me which one.
Yeah.
Which one is what.
Okay, sir. Yeah, sure.
Yeah. So which one is this particular vessel?
Which one, sir? I cannot see.
Good.
I will clear first.
Okay, I will just put a different color. Which one is this? Can you guys see?
No, still we cannot.
I think you might have to completely erase.
Yeah, I'll clear first.
All clear? I still see a blue mark on your at the top of your.
I will erase it. 1 minute. Sorry.
No problem. Take your time.
Okay.
Can you guys see the red mark there?
Yeah, I can see now. It is LAD. So that
yeah.
Descending. Yeah, it is going towards the apex. It is LAD.
Yeah. Now, can you tell me which one is this branch?
Oops. It's not coming.
Can you see that?
No, still we cannot see them.
Still not see it?
No.
Oops. So now all of them appear together.
Yeah, suddenly.
Yeah. So can you tell me which one is that?
Yeah. Okay.
And which one is this?
I think in center it is, I think, Remus. All right.
Yeah, that's it.
And the behind the back is it is a circumflex. But I cannot see properly.
Oblique, yeah. OM, yeah.
That is OM. Okay.
OM, yeah.
Okay.
Okay. Let's take this off and just for the rest of us, let's just 2 seconds. Not able to erase them myself now. Not able to erase them myself. I'll unshare them and then share them again. Oh, it's clear, isn't it?
Yeah, it's clear now.
Okay. So that was what it was earlier. But let us just figure out what are these views basically.
Mhm. Very important.
What does that mean actually? So if you see a pattern that we saw the first time where LED, where you see the LED going down from the top like that, that is the RAO view. If they say that it's a RAO view, then it's clear that that is the LED, right? If you see another one down there, it is the RCA. But if you see a pattern, where there is a vessel going like that, that is the LED. And if they've clearly defined that that is the LAO view, then that is the LED, not this one here. Yeah.
Mhm.
So just remember this pattern, that if it's LAO, then it goes sort of you can say from 7 o'clock to 1 o'clock position. If it's going from 3 o'clock to 9 o'clock position, or 9 o'clock to 3 o'clock position, then it's a RAO view. That's for LED. Then the rest will fall in place. The OM will be here in the RAO view, and OM will be here in that view. And sometimes you see right coronary in a LAO view on the side. Now, how does this view work? Basically, in this particular view, you have the scanner on the left, on your left side, isn't it? Am I saying right, Nitin? Am I correct? In the RAO, is the scanner on your left or on your right, and the screen on your right?
On my screen.
Where is the rays coming from? Are they coming from your left side towards the screen on your right side?
I think RAO, I'm not sure, sir.
Not sure. Now I'm getting a bit mixed up, but basically, what you can see here is this cross section here, that
mostly it is coming from the right side of the patient.
The right side of I think you're right. Yeah, it's coming from the right side of the patient, and the screen is on the left side. That's correct. The rays are coming from the right side, and the screen is on the left side. And from the LAO, it's the rays are coming from the left side and getting the picture on the right side. But the oblique part is that how is this whole thing angled? So if the patient is lying down, let me just put up a whiteboard. If the patient is lying down like that, then if this side, which is towards the screen, is your left side, and this side is the right side, it is outside the screen, the scanner is tilted. The angulation of the scanner will determine that what angle it is, if it's at 30 degree, or if it's at 60 degree, if it's further angled, that will determine the angulation at which it is scanning the heart. So I don't know whether this has made it a bit clear for you, but this scanner will be moved according to the angulation to get the vessel view during the scan. So that determines whether it's a LAO 30 degrees, 60 degree, and that will give you a particular pattern. But most importantly, in this particular Viva, you just need to know the difference between LAO and RAO. But the most common view that you get is this view, RAO. Yeah, that is the most common view that you'd get. Unless if this is not clear, then you ask the examiner what view it is and make a call from there. But this is going to be the most common view. Okay.
Okay. Thank you.
Let's just quickly go through one more topic before we wrap up, related to that is also quite important: thoracic and aortic aneurysm. You should know what is the classification of thoracic aortic aneurysm, DeBakey's classification, which is type 1, 2, 3A, and 3B. And which I do not remember the top of my head about the mortality and which ones which are the ones that yeah, the mortality rates of these, but you can certainly see that type 1 and type 2 are certainly the ones which are involving the vessels, the vessels going to the head and neck area and upper limb area. So that these will certainly be the more sort of tricky ones, and a full graft is replaced. This thing is all taken off. So this whole thing is taken off, and the whole thing is replaced by a graft which has these particular vessels in it, and individual vessels are plumbed into these sort of these appendages for these vessels. So it certainly has, these have higher mortality. Yeah, for dissection, for aortic dissection, definitely. Sorry if I didn't use the word dissection. So to know the terms, that to know the classification, that here is the DeBakey's classification, and these are the 3 or 4 different ways: 1, 2, and 3, and 3 is divided into A and B. So that is something else you should be, I think, before wrapping up cardiac or cardiothoracics, we should just know this bit to be this bit as well. Very unlikely to come, but at least you have got some idea about the classification. At least if it's a superficial question, that can you classify thoracic aortic aneurysm, you can just say it's a DeBakey's classification, 1, 2, and 3, and 3 is further divided into A and B. If they have time, they can go further in, but it's very unlikely. Okay. Okay, guys. I think anything else you guys think you need